How are you? Hope you're doing well. I appreciate your willingness to wear your mask while I'm here. Okay, it's important as healthcare providers that we are doing everything at this point to protect ourselves. So it is my preference, if you're at a table, unless you're having a drink, you have your mask up, please. I'm caring for COVID patients right now at our hospital. I don't want to bring anything to you. I protect myself when I'm caring for them, and I ask you to protect me. I'm going to talk to you today about physical therapy and occupational therapy. I can even answer some questions about speech therapy if you want. If anybody's interested, I'll try to cover most everything for you. Have you all watched a video this morning specifically about PT? What did you think about that? Any thoughts or comments? Did anything surprise you in that video? What about you? Anything surprise you? No? No? Who's interested? What do you think? You're interested in PT? Yeah?
I really liked, especially when they were working with like the people who were in the military and got injured. I thought it was really cool watching them go from like with their prosthetics being able to climb and stuff.
Yeah.
I thought that was cool.
So she was talking about the injured soldiers, how that, that's pretty cool. What about the variety of stuff? You saw kids getting therapy, you saw adults getting therapy, you saw elderly people getting therapy, right? So just like health, anything can go wrong with anybody at any stage in their life. As healthcare providers, we've got to be able to provide that care for those folks. So you see that variety that you have. In our clinic, we do pediatric therapy. We see little babies before they can walk, before they can sit up, who may have something wrong in their early stages of life. They need therapy. We see people all the way up through the end of life as they might need us to do these things. What was this in the video? What did you notice that they were, what's kind of the overriding theme about what these physical therapists were doing with each of their patients? Just really high level. What were they focused on?
Trying to improve their skills.
Skills, trying to improve skills.
ADL.
Daily, activities, daily living, those types of things. Those things all depend upon what, though? Movement. That's what I'm looking for, movement. They all depend upon movement, and as physical therapists, we are experts in movement. All right? Every morning, your alarm goes off. You got to at least roll over and reach for it, right? To shut it off. You got to push yourself up to the edge of the bed. You got to stand up. You got to walk to the bathroom. You got to shower. You got to brush your teeth. You got to put on your clothes, tie your shoes, get breakfast, walk to school, drive to school, whatever it is you do. Everything you do depends upon movement. It might be simple as hand movement. It might be shoulder movement. It might be whole body movement. It might be walking, whatever it is. But when you think about physical therapy, and I'll include occupational therapy in this, we are looking for impairments in the person's ability to move, okay? And we're trying to solve those problems, help them adapt, improve their movement so that they can function. So you mentioned ADLs. You can't really brush your teeth if you can't grasp a toothbrush, right? Occupational therapists work with these types of skills, these activities of daily living, whether it's dressing, brushing teeth, washing face, doing your hair, tying shoes, buttoning your shirt, all these things that use your hands, fine motor task, your upper extremities. That's kind of occupational therapy. It includes those things with children as well, including handwriting and other coordination tasks that children may do. As physical therapists, we're involved more with gross motor movements. So I talked about getting out of bed, you got to roll, right? So we got to roll out of bed, push ourselves up, stand up, walk, balance, stay upright, hold our postures, okay? You saw some people in that video that are in wheelchairs. They're in wheelchairs because they can't stand, right? They don't have that ability. And so in those situations, there's times where our therapy changes from maybe this person can't achieve what you and I can with their therapy, so we have to make changes. We have to find adaptations. Maybe that's a device of some sort. Maybe they're walking with crutches like that kid was. Maybe they're in a wheelchair and we have to teach them wheelchair skills or how to get in and out of the chair. So wide range of things, but the point I wanted to make to you is that physical therapy and occupational therapy very much focused on movement. Maximizing movement in order to maximize function. Okay? You didn't get to this building without your ability to stand on your 2 feet and walk here, right? If you lose that, I saw somebody have a boot on? Who? Yeah, it's right in front of me, sorry. You could have kicked me with it. Yeah, things aren't quite as easy right now with the boot, right? Yeah, what's your name? What is it? Haley? Okay. What's been difficult for you, Haley, because of this boot? Everything? Yeah? Like what? Driving? Is it slower for you to get from place to place? Yeah. Yeah. What else? Just walking, yeah. And this is just no, I'm not downplaying whatever's going on with your foot and ankle, right? You may have a fracture or something, but that's relatively, simple to deal with, but still it affects your day, doesn't it? Yeah. It really affects your day, affects your ability to function. So maybe we need to see you in therapy at some time, get you out of that boot, get you walking again, get you back to normal. Great example of what we might do, okay? We see patients in a lot of settings. In Monette, I practice in an outpatient clinic. Patients come to us, we take care of them, they go home. We also take care of our patients at Cox Monette Hospital. We see patients, you may see some of our therapists in your school, working with some of your classmates. Maybe you saw this when you were younger. It's always more common for younger kids to have therapy needs, physical therapy, occupational therapy, or speech therapy needs when they're young and developing these skills. You talk about skills. Maybe it's with speech, it might be language skills. So we're in schools, we're in nursing homes, we're in hospitals, we're in rehabilitation facilities. These are places where people are staying specifically to be there for therapy, okay? To recover from something that's really knocked them down. Right now, as we recover COVID patients, this is a huge deal. We're seeing patients in our hospital that come to us after being in a bed with people working on them trying to save their lives for weeks. And they come to us and they're not even able to reach their arm forward to grab something. They're that weak. They can't lift their legs up off of the bed. They're that weak. They can't sit up with somebody propping them up at the edge of the bed. They're that weak. So this is a huge thing that we're seeing right now. We've never had to deal with this type of patient before. Yeah, occasionally we have a patient that's been ill for a long time, but this is happening every day. We're seeing these types of patients who are really, really weak because of this illness. So we're in hospitals as well. There are also a lot of other places you find therapists. Some are in the work setting. So you may have a therapist that's hired by a company whose responsibility is to keep their employees healthy or to take care of their employees to make sure they're not getting injured on the job. Okay? Therapists may be in college settings with team sports and with athletes. So a lot of different places that we work. So there's a good variety of opportunities for you as a PT, also as an OT and speech therapist. I'll pause for a second. I want questions, guys, because I don't know what you want to know or what you're interested in. So, kind of shoot me a few questions, if you would. Yes.
What are some ways that you work with babies?
So, I don't work with babies personally, but what I can say is that physical therapy and occupational therapists sometimes start their treatments in the NICU, okay, with an infant, with a baby that is just a few days old, because oftentimes there's recognition that maybe this baby was born prematurely, and there are techniques that they use with those premature babies to help simulate some of the things that they need to develop, help them develop those skills, usually in movement. Okay, movement-based skills that A normal, you don't think of a baby moving that much, but they do, okay? They do. Maybe it's not purposeful. They're not reaching out and grasping something, right, until they get older. But some of those movements and positioning, the positions that they're in, are important for that early development. So as early as, still in the hospital, in the NICU, they're working with them, and then following that care as they grow and develop through life. There's times that we see kids from, first few months from birth up to the point that they're teenagers because of some congenital birth defect, birth injury, whatever it might be. Yeah.
How long did you go to school for?
Oh yeah. How long did I go to school? So physical therapy right now is the route to get to be a physical therapist starts right here. What you're doing right now. I usually tell my classes, I was in this class many years ago before Mrs. Schmidley was here, and this class was important. Don't think it's not. Whether you want to be a nurse assistant, you want to be a nurse, you want to be a doctor, you want to be a respiratory therapist, a physical therapist, whatever, right now you have the opportunity to learn very important basic patient care skills. Okay? Things that I learned in this class many years ago, I still use in my practice every day. Okay? I still use those skills. So don't think this is for nothing. This is very important that you're here if you want to be in healthcare. But it starts here, in college. As an undergraduate, I think your focus if you want to be a physical therapist, needs to be on a sort of pre-physical therapy route in the first 4 years of school. For me, it was exercise and sports science. It might be biology. It could be kinesiology, depending upon where you're doing your undergraduate studies. For me, it was at Drury University in the exercise and sports science program. I was able to take the classes at Drury over 4 years, earn a bachelor's degree, but those classes were the prerequisites I needed to apply to the graduate physical therapy program. So I'm in school for 4 years, I graduate, I get accepted, I go to University of Missouri for 3 years. So altogether, you ask the question how many years? It's 7. 7 years of college is what my experience was. That could happen a little bit quicker depending upon, you guys have so many opportunities for college credits when you're in high school now that I didn't have back then. So some of you may be entering college next year already as sophomores. I didn't have that opportunity. But it's going to be about 7 years. You graduate as a physical therapist right now. All programs are doctorate level programs. You will graduate as a doctorate of physical therapy. Yes?
Do you guys relate your treatments to any chiropractic?
Say it again.
Do you guys relate your treatments to any chiropractor therapy?
So you're asking about the connections between physical therapy and chiropractic medicine? There are some connections. There are some similarities in what we do. Examples are movements of joints. Okay, mobilization of a joint in the spine is something that we would do similarly. We do we might traction the spine, so put it on a device or machine that separates the spine a little bit and gives it relief of compression. We might do electrical stimulation therapies. Chiropractors also have other modalities and things that we don't do. So there's things that are unique to their practice and things that are unique to our practice, but there is some overlap. Yep.
You talked about the variety of places you can work with your degree. Does the schooling change depending on what specifically what you want to work with, if you wanted to do? Like, you know what I'm trying to say?
I do. So I talked a little bit earlier about those different settings. You might be in the hospital, you might be in a school setting, you might be working with athletes or an outpatient clinic, right? So you're asking the question, does your school, what happens within your graduate program, does that change depending upon what you want to do, right? It doesn't. It doesn't. So when you go, the curriculum you'll go through will be a very general therapy instruction curriculum. They'll teach you how to take care of kids. They'll teach you how to take care of adults and older people. They'll teach you how to take care of people with orthopedic injuries and those with neurological injuries, okay? So you're going to get instruction with everything. Where it comes into play is really where you focus your attention when you go out into the clinical world during your school. So you'll be required to do clinical rotations as a physical therapy student when you're in college. This means there'll be periods of time, 6, 8 weeks, where you'll leave campus and you'll go to somewhere like my clinic, or you'll go to a hospital somewhere. You'll travel, you'll spend time there with a therapist who will teach you, and you'll learn from them on the job. And so it might be during one of these clinical rotations that you think, oh my gosh, I love this. This is exactly what I want to do. And that's what you want to do upon graduation. But the curriculum and what you're learning in the classroom in college doesn't necessarily change. It really is on you to sort of find that specialty area, if you want to say, of physical therapy, or that setting you want to practice in, and then that's kind of where you drive your focus. So much of what you learn in physical therapy does also come once you graduate and you get in the working world, right? You guys are going to find that here too, that as much as you have instruction here, even hands-on experience, you'll find yourself continuing to learn when you get out there. I mean, you learn some skills here, but you'll continue to learn. Even as good of instructors as you have, don't ever stop learning. Yep.
What is your hours like? What is your work schedule?
Well, a nice thing about therapy professions is that really there's no need for 24/7 therapies, right? I mean, we don't have to be in the emergency room 24/7. We're not taking care of patients overnight in our hospitals. It's a day job for the most part, and your hours may vary, but it's usually, it's a day routine, which is nice. There are weekend needs from time to time, depending on your setting. If you're in the hospital, you probably have to continue to care for those patients on the weekends. But it all depends on where you're working, what their policies are and such. But, it's a good job to have for just quality of life, compared to some others that sometimes require some things that, longer shifts, overnight shifts, weekend shifts, those types of things. Therapy, you really don't have to worry about that too much. So, a little bit better for work-life balance, most cases. Good questions, y'all. What about others? Yep.
What's your average salary?
Obviously that changes with time. For a physical therapist right now, its starting salary is going to be. This is gross. This is not what you're taking home in your check, but what you get paid throughout the year is probably around $50,000 to $55,000 a year. That's a little bit less for a speech therapist, somewhat comparable for occupational therapists, maybe just a little less. For assistants, so I haven't talked about physical therapy or occupational therapy assistants. So these are, this is a person who doesn't have all the responsibility that a therapist does. So you have PTs and OTs, and you have PTAs and OTAs. For PTs and OTs, their primary responsibilities are to evaluate patients. So when they come to see us for therapy, a doctor writes an order for you to come do therapy with us. We evaluate you on your first visit. We examine you. We try to figure out what's going on. What are your needs? What's wrong? What is your ankle stiff because you've hurt it? Is it weak? Is it painful? Is it swollen? We measure things. We document that. And based on those impairments that we see, we develop a plan of care and we set goals. We want to set a goal for you that you can return to walking normally again without having to wear your boot and you don't have pain, right? That would be ideal. So that's your goal. So we set those goals and we establish what we're going to do to get to that point. What treatments, what activities, what therapies are we doing? That's the plan of care. So therapists are responsible for that. They're responsible for monitoring that plan of care and for carrying out that plan of care. So I could, as a therapist, I'm going to treat somebody. Hands-on. For an assistant, an occupational therapy assistant or a physical therapy assistant, they are carrying out the plan of care. That's their main responsibility. So what we develop as therapists, they take and they do. So they're going to do hands-on therapy with somebody. They're going to be doing some assessment as they go and trying to pick up, is this working? Is it not working? Do we need to change something? Or do we just keep going because things are going well? If we need to change something, it comes back to the physical therapist to make the decision about the change in the plan of care. The therapy assistant just carries that out and monitors the patient's response to it. That maybe answers some questions about those two different paths, okay? Two different paths. So important to know that it took me 7 years to be a physical therapist. That's what you're going to probably see right now. If you want to be a PTA, it's an associate's degree. Some of them are moving to bachelor's degree programs as well. So bachelor's degree, you're looking at 4 years. Associates, you're looking at less than that, depending upon where you go. So if you want to get in and out of college quicker and have a career, you can be a physical therapist assistant or occupational therapist assistant. Similar work, not as much responsibility as an assistant. Also, because of less educational requirements and less responsibility, comes less pay as well. Okay, less pay. For assistants, starting out probably around between $25,000 to $30,000 a year as a gross revenue or gross income compared to therapists at this point. Okay? Good questions. More? Yep.
What are some examples of some exercises or activities you might do?
Oh gosh, I mean, I can't even begin to. I like your question. It's just really hard to answer because our plan of care with therapy is broad. All right, so it may be just simply stretching something, or it might be doing a strengthening exercise with resistance or without resistance. It might be that I'm putting my hands on you and I'm trying to move a joint with my hands. I might be trying to work your muscles to achieve some sort of relaxation because you have some knotting of muscles or something like that. You know, it might be a hands-on, we call manual therapy techniques, okay? I might just be teaching. So as therapists, we teach a lot. So I might be trying to work with somebody how to coordinate walking again because they've lost that ability because of an injury, stroke, whatever it might be. So I may be teaching. I may be working on balance. So I may be having somebody, put feet together and turn left and right and maintain their balance. Maybe I have them stand one foot in front of the other and reach and work. So maybe my answer has helped you see that I think a lot of people have this idea that physical therapy is you're going to come in and you're going to do exercise only. Therapy is not just exercise. A large part of it is because so many of the things we deal with are muscle or joint or joint injuries. And those do benefit mostly from exercise. They also benefit from other things. We might apply a treatment to somebody. Maybe it's electrical stimulation for pain or swelling. Maybe it's, sometimes we do ultrasound. We have a treatment where we can deliver some medicine through the skin with some electrical stimulation. Sometimes we use tools to work somebody's tissue or their muscles. I could go on, but point is, huge variety of tools in our toolbox to take care of somebody and their specific problems. Yep.
How long did it take you after you got your certification on that to get a steady job somewhere that you can use it?
Right away. I went to work, graduated in May. I went to work in June, but that's because I got married in between there. I could have gone to work right away. As physical therapists, when you graduate from an accredited physical therapy program, you do have to take a test to actually finalize the process. You have to take a national board exam, okay, and pass it. Or otherwise you don't get a state license. But in between the point of time where you graduate and the time that you take that exam and pass it, there is an opportunity for you to go ahead and start working with what's called a provisional license. So the state can grant you a license to practice with supervision of an experienced therapist as you study and prepare to take that board exam. Okay, that's how it works in physical therapy. Speech therapy is a little bit different. Occupational therapy is like that, is like PT though. Okay, good questions? But if you're wanting, you may also have been wanting to know about like the job prospects, right? What are the opportunities to work? and I wish I had better numbers on this, because I don't. I haven't stayed up with this, but there are still jobs. They're out there. I think we're starting to fill that need a little bit better, so it may be a little harder to find work as a physical therapist than it was, say, 5 years ago. But there's still a pretty good need. There really is, and I think we're seeing that. I think we'll continue to see that for a while. I think the same is true for PTAs, but they may still have a little bit harder time right now finding work than a PT. But most PT graduates most of the schools that are graduating PTs are seeing 100% placement usually. Just depends on where you're at. Right now, I don't have an opportunity for a PTA. I don't have an opportunity for a PT or an OT right now, but things are changing, and we have things coming. We're getting busier, and so I may in the next 6 months have opportunities for somebody. So just kind of depends. Good questions. What else? I appreciate the questions, guys. Yeah.
So how has COVID affected your job?
We're doing things we never have done before. Early on, it was, we responded to this in the spring pretty strongly, even before it was truly here, I would say, and it was like it is now, where we kind of shut some things down. So we stopped doing surgeries at our hospitals. And doctors weren't seeing as many patients. People were staying home as they should have. So we just didn't have very many people coming to the hospital. And so we had to change the way we did business. I mean, some of my employees went home and took days off. We found other jobs for them to do within the health system, like screening temperatures and symptoms at our doors. Cleaning things. Some people went to work as in environmental services, cleaning the hospital. Some went to work with doing groundskeeping work. We just tried to keep everybody employed. So that was huge at first. It was our efforts were mainly towards trying to keep people employed and find work for them to do, because we didn't have patients coming to see us much. That gradually changed, and we came back to some more normalcy as far as doctors seeing patients, doctors sending patients to therapy, and our numbers increased. And now our focus is on keeping each other safe and healthy. That's it. And we're doing things, like I said, we're wearing masks. I wear eye protection when I take care of patients. Anytime I'm with a patient, I have to wear eye protection. We are paranoid about washing our hands and sanitizing our hands. We're wiping and cleaning everything we can, that our patients come in contact with when they're in the clinic. So those efforts have been ramped up greatly. And we just have to be more vigilant about taking care of each other and our patients, and asking our patients if they're healthy as well. I mean, we can't see anybody who has symptoms because of the potential for them to spread that to us. In our hospital, we're seeing COVID patients, so we're had to make a lot of changes to the facility and to our processes to make sure that we can care for those patients, but keep us safe, keep our coworkers safe. So that means isolating these patients in certain areas, and steps that we take if we need to go in and see that patient in a room. There's very specific steps that we take to protect ourselves with PPE. Putting it on, taking it off. It's kind of grueling, if you would, but it's essential that we do those things to take care of our folks. So maybe that answered your question. Yeah. Yes.
So if we didn't want to move to like a big city, what would those job opportunities look like around here?
Yeah, there's therapy opportunities just about anywhere. I mean, maybe not in real small town USA, but probably more than anything, if you're in a community that has a hospital, there's going to be an opportunity for hospital care and outpatient care. Cox Monettes being an example. We got hospital physical therapy, we got outpatient therapy. Other places, there are definitely, you're going to find school systems need therapists to take care of their kids. So you're going to find that because most every community has a school. So there may be those opportunities. Say it again.
Like in those environments, what would like the majority of like treatment being used, like the type of people, type of injuries?
Well, so I guess so she's asking about what kind of patients do you see in a small rural area compared to, say, maybe in a more urban area, right? I would say in a rural area like this, what kind of people live in these communities? What? Some are elderly. What else? You have people who work on farms. You have farmers. What about Monette specifically? If you drive out around town, what do you see? You see factories. You see a lot of people working in factories, whether it's manufacturing, processing. This is a lot where you'll see a difference. An urban area, you might see a little less of that, but in the suburbs where you have these factories and these places where you're doing physical labor all day, there's plenty of opportunities for people to get injured or to have repetitive stress injuries. They're reaching over and overhead a lot to do their work, and they get shoulder pain. Okay, you get a guy that's out farming, he's lifting feed or throwing hay bales or something, he hurts his back. So I think we see a little bit more of that. You're right. It seems like in the suburbs and a more rural area, you do have maybe an older population. Okay, so you are dealing with people with knee replacements and such, but you see that in a more urban area as well. No doubt about it. But that may be where some of the difference is. The way we treat people doesn't change. Just because I'm in Monette, Missouri doesn't mean I treat differently than somebody. They may have more. They may be at a larger facility. They may have more space. They may have more equipment or supplies. But that doesn't necessarily mean that that location is going to take better care of that patient than I can here with what we have. You've been to our clinic. You've seen what we've got. It's not bad, right? We got a pool, for goodness sakes, right? Okay, we can do pool therapy at our place. So we got a lot. We can take good care of people. Did that answer it? Yeah. That's a good question because it is a different mix. When I was a clinician, so especially hospital care too. So that's maybe where hospital care differs. In our hospital, it's a 25-bed critical access hospital. We take care of a lot of different types of patients, but not to the same extent that, say, a large medical facility or a academic institution might. So I spent some time at Presbyterian Hospital in Oklahoma City when I was doing my clinical rotations, and I saw people the next day after having their chest split open and having heart bypass surgery. We don't do that in Monette. I saw people who had strokes and brain injuries, spinal cord injuries, all these things. We don't see that at our hospital in Monette just because of our level of care. So maybe where you see the biggest discrepancies in what you might be seeing is in an inpatient or a hospital setting based on that facility's level of care. Okay? Anything else? Yep.
If a patient is pregnant, does that affect what kind of exercises they can do?
Yeah, it can. It sure can. There's certain things that we won't do with pregnancy that we might with another, and it does depend upon the stage of pregnancy. So it's specific. But we do. I've seen many pregnant women in my career because as you may imagine, pregnancy can bring on some aches and pains, changes to your body, spine as you carry more weight, your back can start to hurt. Your joints become looser as a natural process of that pregnancy as it goes on, as your body prepares to give birth. So ligaments start to get looser. That can affect your pelvis or other joints as well. So plenty of things that we may need to see somebody for during pregnancy. Yeah. And we have to keep it in mind. We do keep that in mind, right? Yeah, that's those special considerations. All right, any other questions, y'all? Doing good. Yep.
Can you talk to us about the therapy pool that you guys have?
The what?
The pool that you guys have at the clinic?
Our pool? Sure. It's a, if you're thinking about a pool, you're thinking of something maybe kind of big and long and right that you can swim in. This is not a swimming pool. It's not, it's a therapy pool. So it's probably like from this edge of the table to the other edge of the middle table, okay? So it's about that long and a little bit wider, than the table. It's about a table and a half. We keep the water at 93 degrees, so it's really warm. It's not hot, but it's warm. So our patients get in, they can relax. They're not chilled. They're not tense. They can relax. The warmth of the water helps to improve extensibility of their tissues or their joints, their muscles in their joints. So if we're working on trying to stretch something out, that helps, okay? When you're in water, what are the properties of water that might help us in our therapy? Buoyancy, I think I heard buoyancy, right? So I weigh what I weigh right now. If I get in the water at my waist height, I only weigh 50%. I only am bearing 50% of my body weight on my feet. If I'm up here about mid-chest, about 75%. Sorry, I'm only bearing 25%, I should say it that way. 75% of my body weight is taken off. So you've hurt your ankle, you need to start doing therapy, but it's kind of too painful to put weight on it on land. So we can put you in the water and you can do movement therapy, stretching, range of motion. We have a treadmill in the bottom of our pool, a treadmill that's built into the floor, so we could teach you how to walk on the treadmill under the water or in the water, and it's not going to hurt your ankle as bad as it might if we were up here on land and you're putting all of your weight through it at first. So water therapy takes away some of the compression forces on the spine and on the joints. The warmth helps, the buoyancy, like we said, helps. There's also resistance in water, right? So when you move part of your body in water, the water provides more resistance than the air does. So if we wanted to strengthen something, we could do leg movements in and out and improve your strength that way. Okay, so there's resistance to water as well. Those are some of the things we do in our pool. Our pool has, like I said, treadmill. It also has resistance jets, so I can push water at you and make it harder for you to move against it. We also have some hoses that we can plug into those jets, and it becomes like a massage hose. Okay, so we can take that hose and work somebody's muscle if they've got a sore muscle or tight muscle. We might benefit from massage, might help with pain. Okay, so I also have a camera under the water, so we can watch somebody from two different angles as they're walking on the treadmill, and help them to learn how to move or walk again. We can give them feedback because we can see underwater with it. Sound good? You want to come get in today? You want to go swimming? We don't swim. Like I said, it's not a swimming pool, so we don't do swim. It's not like we train people to swim. So, yeah. All right, any other questions? Anybody want to sing? I think I do this every year, and I'm sure I'm missing plenty of stuff I've talked about in the past, but hopefully it's helped. Let's shift gears, and let me talk about what I think is important for you. And I want all your attention here, because I think it's important that you know, as caregivers, how to protect yourselves from getting injured, right? Nurses get injured, therapists get injured. When we're caring for patients, sometimes we have to touch them and move them, lift and help them. And in that process, there are opportunities for us to get injured. The risk goes up. But I really want to talk to you about how you can minimize that risk as much as possible when you're caring for somebody. Because if you get hurt, work's no fun when you have to work with pain, right? Some situations you may not be able to work because of that pain. If you can't work, can't make a living, life's no fun. Okay, so really important. that we do this. So I want to start talking about your body position and your posture, all right? Your spine and your lower extremity joints, they like to be in a certain position most of the time, and then we call it like a neutral position. So this is, if I'm standing up right now, this is sort of a neutral position of my spine, of my shoulders, of my head and neck, all right? My body is okay with this. They like it. It likes this. Best example I can give you, is that if you take your first finger and bend it back, just do this with me for the heck of it. Just bear with me. Bend your finger all the way back as far as it'll go. Does that hurt? A little bit, right? Take it away. Does it hurt anymore? No, but when you pull it back, you feel some stretch, you feel some strain, right? Now, what if you did this for like the next 3 or 4 hours? Okay? Would that feel good? No, it'd probably get worse, right? It's the same concept when we're dealing with the joints in your spine. If you stand around like this with like really bad posture, if you sit like this with really bad posture, this is going to start to hurt when you hold this for a couple of hours, because essentially you're taking your joints and you're doing this like you did with your finger and holding it there for a long period of time. Okay? So I talked to you about posture because it's really important that you know how to achieve good posture and you maintain it as you're working. Because just as much as I say, sustaining bad postures hurt, if you do work in bad posture and then you apply a force to it, it could hurt. Okay? So if I'm going to lift on somebody or bend or pick something up off the floor and I do it with my back curved out and I don't use my hips and my knees and I just bend over and pick something up, right now it's okay. But when I apply a force to try to lift that up and my muscles kick in and my spine compresses, then the opportunity that I strain a muscle, that I bulge a disc, have a disc injury in my spine, all these things, they go up. So let's talk a little bit about this and how it applies to you caring for somebody. All right. Let me just have somebody willing to come up on the table, please. Not the injured one. Don't make her come up. Yeah, come on over it. What's your name? Jesse. Hey, Jesse. Why don't you lay down on your back? This is not a great example. We're using this stretcher just because it can come out the doors. But typically with a hospital bed, what's the position of that hospital bed? It's quite a bit lower, right? So this is high. This is actually a good example, though. If I'm going to be taking care of Jesse for a while, if I'm going to be doing therapy with him, moving his legs, if I'm going to be helping him with a bath or whatever it is that you might be doing for this patient in the hospital, it's a good idea. Bring him up to you, all right? I don't want to have to take care of Jesse like this for the next 30 minutes. My back's going to get tired. I'm going to set myself up for injury, okay? But this is much better. And your beds in hospitals or nursing homes, these facilities, should go up and down, okay? Should be able to raise them up so that you can do your work, waist level, don't have to bend over so much. This is much better for your posture, okay? What's really important, though, when you're done? You bring them back down, right? Right? We don't want our patients hanging out in the air when they get up. They don't like to jump out of bed. Most of them can't. Okay, so this is a good example of what you may be able to do to help yourself. It's not always possible, though. There are times when, let's say I want to roll Jesse. I need to help him roll from side to side. I'm going to have to pull on him or push on him. I'm going to do this. I'll move this table a little bit. Do it kind of from the side here so you can see this a little better. Use your legs. Okay, most common injuries you're going to have are spine injuries. neck, mid-back, and low back, okay? You got, muscle in your neck and your low back and your mid-back, but you've got stronger muscles here, all right? So if I'm going to have to bend over or I'm going to have to roll Jesse on his side, imagine the bed's lower for me. But it's really important that you really bend with your knees and your hips, and you keep everything from the waist up pretty still. So you notice I really don't change my trunk posture when I go down. I just bend my hips and my knees, and it gets me to the level I need to work at. Maybe my stance is wider, depending upon what I'm going to do. Maybe I'm split stance. But for instance, if I'm going to roll him, don't stand up straight. Don't bend over with your back like this and pull with your arms. Use your legs. Split your stance. Bend your knees and your hips. Keep your back pretty straight. And use your body weight to move somebody, okay? Use your body weight to move them. Don't just pull with your arms, okay? Use those legs as much as you can, all right? We'll see a little better here maybe when we stand somebody from the chair, okay? But generally, keep a neutral position of your spine from the waist up. Avoid rounding your back out. Avoid leaning back, okay? I typically show steps on how to get somebody from supine on their back to sitting. We'll do it best we can here with this high stretcher. But one of the best advice I can give you before you ever enter a room to see a patient, know what you're going into. Okay? Know the patient you're about to see and what their abilities and inabilities are so that you're prepared. You're prepared mentally, you're thinking through the steps of what you're going to do to care for that patient, and there aren't any surprises. When you know what to expect, you also don't look like an idiot to your patient when you go in there. If I go in there and Jesse's perfectly capable of sitting himself up at the edge of the bed to prepare to go to the bathroom, and I come in and I start pulling on Jesse and say, okay, Jesse, I'm going to help you get up. Let me help you. And he's like, whoa, wait, I can do this myself, right? Clearly, you don't know who you're going to see. You don't know what they're capable of doing. And this patient now has lost some faith in your abilities because you don't know what you're doing. Okay? Be prepared. Talk to the nurse in charge of this patient before you go in. What do I need to know? If you don't know it already. Figure it out yourself. What are they able to do? Okay? That's important. Be prepared with your equipment. Gait belt if you need it. Walker, wheelchair if you need it. Whatever devices you might need for this patient and what you plan to do with them, make sure you have that stuff there. If I get Jesse set up at the edge of the bed, and he's not very good at sitting at the edge of the bed, sit up for a second. Bring your legs over here. Okay? Let's say his balance isn't very good and I kind of have to keep my hand on him, but my stuff's over here, and I've got to walk away. We've just created this opportunity for something bad to go wrong, right? So be prepared with what you need. Worst case scenario, you got to step out of the room, and this person's not good to sit at the edge of the bed, lay them down. Get them in a comfortable position. Make sure they're safe. Go get your stuff, come back and start over. Okay? Don't cut corners. Don't do anything to harm somebody. Okay? Go ahead and lay back down. Instructions. So let's say, in this case, he needs help getting up. He needs my assistance. Ideally, what we try to do is have somebody on their back get to one side or the other. Best way to do it is bend the knees up. To both knees. Yep. And ask them to do as much as they can. If they can roll over onto their left side in this case, have them roll to their left side. If not, you can help, kind of doing what I showed you a minute ago, good posture, a hand behind the opposite shoulder, a hand behind the opposite hip, right above his butt, and you pull. I can't really pull him here, this table's narrow, don't want to pull you off. But you use your body and you pull, okay? And you get them to their side. Once the patient's at their side, next step is to kind of walk or bring the legs off the edge of the bed. Because what these legs do is they serve as kind of a lever. They serve as a lever. So when his legs go down, it makes it easier for his upper body to come up, okay? They kind of help pull it up, go back to your side, okay? So legs off, they lower, and tell the patient to push up with the elbow and the top hand, all right? Not everybody can do this though, right? I wish they could. Wish everybody could roll to their side. Sometimes you have to roll them. Wish everybody could bring their legs off the edge of bed. They can't. Not all of them can. Sometimes you have to do that. Wish everybody could push up. They can't. Not always possible. When that's the case, sometimes you've got to help. So as long as you can get them to your side, you can take your top hand and you can go under their shoulder, not under their head and neck. You're not going to be pulling there. You're going to try to get it under his shoulder. Go ahead and relax your head. And my bottom hand is behind their knees. So what I can do is I can pull the knees off the edge of the bed, let them go down, use my legs, and help them up, okay? And stay with them, make sure they're safe, guard them, all right? Go back down on your side, all right? So notice, when I lift, I'm lifting with my legs. Yeah, I've got to use my right arm to help them up. Yeah, I'm using my left leg, or my left arm as well, but I'm lifting with me, and this would be a much better demonstration if if he was in a lower bed, which he should be, because I would really get down and pull with your legs. But that's important, okay? Don't just jerk on somebody with your arms and your back. You'll get hurt. Always important when somebody first sits up, don't sit them up and walk away. What can happen? They get lightheaded, they get dizzy because they've been in bed for the last 3 days. You know, they're not right. Maybe they're dehydrated. Something might happen. So they pass out on you and end up on the floor because you turned away. It's a problem. Be with them, make sure we're good. You feeling lightheaded or dizzy? No, Jesse's good. And we can go from here, okay? Let's talk gait belts, all right? You'll find different gait belts depending upon where you're at. This is a pretty classic style. You won't find these as much. You won't find these in our hospital anymore because they're cloth. We can't clean these as well. You can imagine right now, everything's got to be wipeable, cleanable, okay? And these aren't. They carry too many germs. But generally, know these gait belts well and know your different types well. This one's easy because you know that have you guys done this? Yeah, okay. You know it goes under the teeth, okay? It locks in place, teeth lock it in place, and you tighten it up. So I'm going to stand Jesse here in a minute. He needs my assistance. What if he was perfectly independent and safe?
I wouldn't need much assistance.
I wouldn't have to help you much. I still might be, probably in our setting, it's probably still a good idea to put a gait belt on. Because maybe he was like walking down the hall by himself yesterday, but maybe last night he had some medicine that's made him really drowsy. Or maybe that medicine has actually caused dizziness. Medicines have side effects, you know. Maybe that medicine caused some side effects, and then when he gets up, something happens and he falls over. If you don't have the gait belt on, you're going to have to answer some questions as to why you didn't, okay? If you did have the gait belt on, you might have been able to slow him down from falling or even stop it, okay? When you put a gait belt on somebody in the sitting position, not everybody's as skinny as Jesse, all right? Many of our patients in our hospital are not in good shape. They're sick. Maybe their belly is even full of fluid, okay? You can tighten it down as tight as you can in sitting, but when they stand up, their body shape changes and your belt will get loose. Don't be satisfied with that. Once they're standing, take some efforts to try to tighten it, okay? You don't want a belt like this on somebody, because if Jesse starts to fall on me, then I'm in trouble. I've got no control over him, right? You know, it's not going to work very well for you. Okay, so you want it snug, you want it tight, you want to feel some like you've got something. It's not going to slip around much when you pull up or down on it. Okay. Why don't you come to the wheelchair instead of this tall stretcher? So let's just say we've got example here, and we can use this example for the bed as well as.
They don't lock.
Not very good at locking anymore? Okay. We're going to use this example as if I'm standing him from the edge of the bed or from the wheelchair or from a bedside commode or toilet, whatever it might be. Okay. I've got the gait belt on. It's good. Let's say, again, you know your patient before you go in, right? We know that Jesse can get himself up out of this chair without me doing anything to pull or lift. So in that case, all I have to do is stand at his side, and he stands up, stand up, okay? All I'm doing is just making sure he's safe, he's balanced, he's not going to tip over, okay? Come back down. Let's say that he needs my assistance though, okay? That could look a couple different ways, all right? Maybe I can still stand to the side, and all I need to do is do a little bit of pull on the gait belt. So do that, and I just kind of help by lifting, give a little extra lift to help. That's all he needed to help get to standing. So we might call that minimal assistance, okay? Once we get to the point though to where somebody requires moderate or more assistance, moderate or maximal assistance, that means I'm going to have to provide at least half or more of the effort to get him standing. I probably can't do that with one hand from his side. I have to go ahead and sit down. I have to be in front. Okay, I have to use both of my legs to help him stand, all right? Guys, this is a point where you can't be afraid to get up close with your patients. You're caregivers now. You got to be okay touching somebody, all right? So preparation for standing, it's always important to try to get your patient to kind of come out to the edge of the chair just a little bit. And see how close his feet are together? I don't really like that, so I'd have him separate the feet a little bit more. Shoulder width apart, maybe hip width, okay? And the other thing I want to make sure he can do is have the feet behind the knees. So his feet, I don't know if you guys can see this, but his feet need to be back tucked under him just a little bit, okay? Let's do a little trick. You run cross country? Yeah. You got strong legs? Sure you do. Stand up. Okay? Have a seat in that chair. About halfway out. Okay? Straighten your knees a little bit more. Right there, right there. Can you hold the chair? Like stand up and hold it so it doesn't slide out. Thank you. Now, stand up, but don't lean forward. Go. Come on. Yeah, you can't, right? You can't do it. Can you try? Okay, I'll give you a little bit of leadway. Now stand up. Yeah, okay, so you made a little bit, right? Try again. You can't do it. No. You can't, because your body weight is too far back. You can't overcome that. So it's important that you get your feet underneath, and you have to encourage your patient, and this is sometimes hard, especially when you're dealing with an elderly patient who has fallen recently. You've got to encourage them to get their nose over their toes. You've got to get your body, upper body forward, your head forward. You've got to move their weight forward, because look what's happening when he moves forward, okay? His butt's coming off of the chair without him doing anything. I mean, he's almost out of the chair. So all he has to do now is just activate his legs a little bit and he stands. But you cannot stand, and you will have people. Try this. Thanks for trying that. I'm going to go back here to Jesse. You will have patients who will try to stand and they're leaning back. Guys, you're going to hurt yourself trying to do that. So, you know, if he doesn't come forward, just stay lean back and try to stand up. I have to pull a lot harder when Jesse's leaned back. So I've really got to encourage my patient to come forward towards me. Sit back down. So have that conversation if you know it's not going too well, if they need that, okay? But you're going to be in front of them because you've got to supply 50% or more of this effort, right? Can't do this from the side. So sometimes you might have to sort of help them practice that move where they're leaning forward a little bit before you start standing. If they're having trouble with that, help them understand that. When you're ready, hands around their side. I like to take my hands and I hook them under the gait belt like this, okay? So I can provide that lift. Sometimes we stand up for a second, turn your back to them. So hands under the gait belt like this, okay? There have been times where I've had to do this and actually pull on somebody's hips to get them to stand up. Because sometimes when I pull on the belt, maybe that's not enough leverage. I've actually got to grab on the back of their pelvis and their hips and pull them towards me, okay? So here on the belt, or I keep the belt with my thumbs and I use my hands to pull and lift this way, okay? Turn around. I just talked about body position and posture, right? Feet apart, scoot out a little bit, Jesse, okay? Knees and hips, they gotta bend, and you can't do this with your back. So I got to squat, I get him to lean forward. Maybe we count to 3, I say 1, 2, 3, lean forward. Notice how low I am, okay? Because I'm going to help him come up, and as I straighten my knees and my hips, I'm lifting and pulling them towards me a little bit, okay? Go back down. Do it again, lean forward, up. It's like you're doing a squat in the weight room, okay? You got to keep yourself in good shape to do this, all right? Make sure he's good, and you're going to your next step, whatever that might be. Maybe you got the walker, you're putting a walker in front of him because he's going to walk from here to the bathroom, or whatever it might be, okay? Don't leave this side. Don't leave this side, okay? Same thing on the way down. The instructions to the person on the way down, make sure, if they can, put their hands back to find the surface they're sitting on, the arms of the chair or the mattress, to lower themselves, okay? And they have to do the opposite when they sit down, okay? When he sits down, he's got to stick your butt out, bend your knees and stick your butt out and let your head come forward. Notice how his head comes forward. Stand back up again. Try to sit down without your head coming forward. Well, that wasn't too bad, but you came forward a little bit. Just try to fall back into the chair. So most of the time, they plop. People can't control it. They lean back to sit down, and they end up plopping down in their chair. That could injure the patient. So make sure that they stick their butt out, bring their head forward, reach back, and lower themselves down easily. Okay? Any questions about sort of body mechanics, how to protect yourself, and how to maximize your strength when you're moving somebody? Anything? Sometimes I talk about, I'll do this real quickly. How are we on time, Ms. Pratton? Okay. Okay, let me spend 5 or 10 more minutes. Is that okay? Go ahead and stand up. I talk about guarding when you're walking a patient or guarding them. Let's say he has a walker in front of him, okay? Act like you're putting your hands on the walker. Oh, here, let's do this. This is your walker. Okay. Where should I stand when I'm walking somebody? Weak side, good. So let's say left side's weak side. Where else?
Slightly behind.
Slightly behind? Like here? No, over here. You guys already know this.
Yeah.
Okay. So I like to be off at an angle. Okay. Off at an angle. Hand under the belt. As they're walking, I'm on the weak side. The reason why, just to drive this home for you, if I'm here, I have the best opportunity to control him if something goes wrong, okay? And here's a couple of examples. If he starts to go to his right, fall to his right, I'm here, and I can pull him back in, okay? If he starts to come to his left, I'm here and can right him. Starts going forward, and I can pull him back. If he starts going back, I'm here. If I walk straight at his side, and he starts to go forward, I don't have the same leverage, do I, to pull him back as I did when I was here, okay? If he starts to go back, same thing. I don't have the same leverage. I'm not there like I was before. That's why I like this. It gives you the greatest opportunity. Here's one more thing, and I hope this doesn't happen to you, but sometimes you never know. It might. Move this out of the way. Let's say he actually starts to go down. And what can I do when I'm in this position to help him come down? Yeah, I can use my body. So if you say he starts to fall down, or like your knees are about to buckle. Okay, one of the things potentially I could do is put him on my knee. If this is a big person, guys, be careful. You may just do everything you can to make sure they get down slowly. And then maybe I could slowly slide him down to the ground so that he's not hurt. He ends up on the ground because there's nothing else you could do about it. Patient lost his legs. They weren't going to stay standing. This is the best case scenario, that I've lowered the patient to the ground safely because I was using the gait belt and I was in the right position, and we can call for help. We can get this patient back up and get him back to bed. You stand up on your own. I'm not listening from there. All right, so another reason why it's important for you to stand back here, because you can bring that patient to you in the case that they, whatever, get dizzy, get lightheaded, lose their leg strength. If I'm right here, that's harder. If he starts to go down here, I've got nothing, all right? I mean, I'm in a terrible position. I'd have to get back around pretty quickly. So best to stay off that back shoulder on the weak side. Take the belt off if you want. Any other questions about patient handling safely, body mechanics? Thanks, man.
Why did you choose physical therapy?
He asked, why did I choose it? Why did I choose physical therapy? I knew I wanted to be in healthcare, just didn't know what when I was in your position. Actually, when I was in this class, I knew at that point I wanted to be a physical therapist because I know this is a silly answer, but it's just the way, when you have an experience yourself and it was a positive experience, it's something you might want to go back to, right? So I had physical therapy when I was in high school for a broken leg. And I had quite a bit of it, and so I got to see a lot of it, both in the hospital. I had surgery, so I was in the hospital doing therapy. I came home, I went to the clinic, outpatient clinic, I had therapy too. So, I had months of therapy and just really liked it, and liked the idea of what I could do to help somebody. So that's it. Pretty simple story. Anything else? Y'all, thank you. Thank you for being attentive and asking good questions. I know it's no fun to wear your mask, but thank you for wearing those as well. Continue to do that, protect each other, and keep each other safe. Thanks.